Hi, I'm here in Orlando at the ASH 2019 meeting. I've been asked to discuss what non-cellular immunotherapies are in development for multiple myeloma. So there are two broad categories that I think are showing some exciting results. The first are the antibody-drug conjugates, and the one that's furthest along in development is called belantamab mafodotin. This is an antibody targeting BCMA, which is a protein that's highly expressed on malignant plasma cells, and it's conjugated to a toxin called MMAF. And the primary mechanism of action is internalization of the antibody-drug conjugate and release of the toxin within the myeloma cells, which induces apoptosis. It also can induce antibody-dependent cellular cytotoxicity and block signaling through BCMA. And in the phase 1 expansion portion, in which 35 patients with median of 5 prior lines were treated, the overall response rate was 60%, including a number of patients with deep VGPRs and complete remissions. And the median progression-free survival in that cohort was 12 months, with a duration of response of 14 months. In a subset of more heavily pretreated patients that were refractory to proteasome inhibitor, IMiD, and daratumumab in that study, the response rate was 39% with a PFS of 6 months. And this is all fairly impressive for a monotherapy in this heavily pretreated group. The main toxicities of this drug are thrombocytopenia as well as corneal toxicity, which is due to deposition of small amounts of the free toxin MMAF circulating. And this was generally manageable with dose reductions and dose delays. The other class of agents that are showing a lot of promise in myeloma are the bispecific antibodies, a subset of which are called BiTEs. These are drugs in which one end of the molecule attaches to a T cell through CD3, the other end attaches to the myeloma cell, bringing the T cell to the myeloma cell in the microenvironment and leading to T cell activation and killing. And so at last year's ASH, we heard about AMG 420, a short half-life BiTE that showed promising initial activity. And at the MTD, 7 out of 10 patients achieved an objective response, including 5 MRD negative CRs, some of which were ongoing. At this year's ASH, we heard about CC93269, a longer half-life bispecific antibody, also targeting BCMA on the myeloma cell. And again, at the active doses of 6 milligrams or higher, 10 out of 12 patients had an objective response, including, again, patients developing MRD negative CRs. The main toxicities of these have been cytokine release syndrome, which tend to be more mild than what's seen with CAR T cells, but still require significant management and hospitalization for initial doses, as well as infections. And so therefore, I think we need to monitor these patients very closely and provide supportive care and immunoglobulin replacement if needed. These last two trials are still relatively early, but showing a lot of promise, and I think both of these classes are hopefully going to provide greater options for our patients with relapsed refractory myeloma.